webinar CME program inauguration. Friends, as we promised, we're going to give 20 webinar CME credits this year. The world has come to a standstill due to the devastating COVID-19 pandemic. The disaster has not dampened our spirit and personal efforts as a physician and healthcare personnel to save thousands of lives across the globe. We're all united in the giant humanitarian effort as a member of one single global medical family. We have lost colleagues despite their selfless services. They're all heroes and angels. Let us all pay humble homage to them by observing a moment of silence.
Can you hear? Can you all hear?
Yes, thank you. We are honored today to have President of American Heart Association, Dr. Mitchell S.V. Elkin, inaugurating the program as our distinguished chief guest and CME speaker. He will be introduced shortly. We welcome you, Dr. Elkin.
Thank you.
It's my pleasure to introduce our API webinar CME chair, Dr. Vemuri S. Murthy. Dr. Murthy is a past chairman of Department of Anesthesiology at West Suburban Medical Center, Oak Park, Illinois. He is currently affiliated with the Department of Emergency Medicine at the University of Illinois, Chicago College of Medicine as the adjunct faculty. Dr. Murthy is a well-known resuscitation educator and trainer, have been involved with the American Heart Association for about 3 decades in various capacities, including national faculty and member of international committee. I thank him and his committee for contributing the high quality virtual CME program for API members and other physicians in the US and internationally. I also thank Chicago Medical Society leadership, represented by Society President Dr. Jay Chauhan, here today, initiating our mutual collaboration in this joint CME endeavor. I now welcome Dr. Murthy to introduce our chief guest and CME speaker, Dr. Elkin. Dr. Murthy, please.
Thank you, Dr. Sudhakar Janlagada. We appreciate your leadership and efforts for initiating ongoing monthly webinar CME programs involving distinguished speakers. We are choosing diverse topics based on the membership input and the need to enhance the quality of our medical practices tailored to the current changing and challenging trends in disease patterns and emerging global pandemics. It's my pleasure to present our webinar CME team, co-chairs, Dr. Naveen C. Nanda, Distinguished Professor of Medicine and Cardiovascular Disease at the University of Alabama, Birmingham, Dr. T.S. Ravi Kumar, Emeritus Chair of Surgery at Albert Einstein College of Medicine, New York, and current President of All India Institute of Medical Sciences at Mangalagiri, India, Dr. Kalpalata Guntupalli, Professor of Medicine and Chief of Pulmonary Critical Care and Sleep Medicine Section at Bentop Hospital, Baylor College of Medicine, Houston, Texas, Dr. Rohit Kumar Vasa, neonatologist at Anne and Robert Lurie Children's Hospital and Chair of Pediatrics and Neonatology at Mercy Hospital and Medical Center, Chicago, and advisor, Dr. Rangareddy, retired Professor of Anesthesiology, Southern Illinois University College of Medicine, Springfield, Illinois. Our 60-minute structured program has a 40-minute presentation of today's topic, embolic stroke of undetermined source beyond atrial fibrillation, followed by a 20-minute question and answer session with Dr. Guntupalli as the principal moderator. The limited questions are randomly selected from the participants. To prevent distractions, we request you to use the chat room for questions only. Please complete the pre and post lecture surveys to receive the CME credits. Now, it's my honor and privilege to introduce our inaugurating chief guest and distinguished speaker, Dr. Michelle Elkin, President of the American Heart Association, American Stroke Association, tenured professor of neurology and epidemiology, and chief of the Division of Neurology, Clinical Outcomes Research, and Population Sciences at Columbia University Irving Medical Center in New York City. Dr. Elkin's research focuses on stroke prevention, inflammatory and infectious biomarkers in stroke risk prediction, atrial cardiopathy, immune therapy for acute stroke, and vascular causes of cognitive aging. He has a long-standing commitment to medical education and research training. In addition to leading the Columbia Neurology Residency and Fellowship programs, he serves as editor of the American Heart Association, American Stroke Association, Stroke Journals, New International Stroke Early Career and Training section. He runs NIH-funded research training programs for residents and fellows. Dr. Elkin has served on several American Heart Association, American Stroke Association committees, including 3 terms on the National Board of Directors, 2 terms as chair of the American Stroke Association Advisory Committee, and co-chair or member of several writing committees for guidelines and scientific statements. He also co-chaired the writing committee for the 2012 scientific statement on the inclusion of stroke as an outcome and risk equivalent in vascular diseases risk course, and currently serves as co-chair of the stroke section of the annual statistical update. My pleasure to introduce our honored guest and speaker, Dr. Elkin. Thank you.
Thank you very much, Dr. Murthy. It's really quite an honor to join you here and to have the opportunity to speak with this group. I'm really delighted to be here, and both on behalf of myself as well as for the American Heart Association, we really appreciate your recognition. I think I probably have many friends. I know the American Heart Association has many friends in the American Association of Physicians of Indian Origin, and I hope some of them are, watching this evening. Of course, I wish that we could all be together in person, but this is a great way to get together, and I hope I can share some interesting information with you. I'm actually a vascular neurologist, a stroke specialist, and some of the work, though, that I'm going to talk about tonight kind of bridges the world of neurology, and especially vascular neurology and cardiology. So it sounds like there may be a lot of cardiologists and cardiovascular disease specialists on, and I hope you'll find this interesting as well. There are probably a lot of people who are not necessarily in those fields, and so some of it will also be a little more basic, geared towards fundamental understanding of stroke. So if I might have the first slide, please, I'll jump right in. So I'm going to talk about embolic stroke of undetermined source beyond atrial fibrillation. And next slide, if you don't mind. Here are my disclosures, just so you know. There are a couple of things relevant to what I'll talk about at the end, a clinical trial called Arcadia. And it's an NIH-funded trial, but we do receive some study drug in kind from BMS Pfizer and some laboratory support from Roche. Next slide, please. So what I'd like to do this evening is talk about what is cryptogenic stroke or embolic stroke of undetermined source. We'll go through some basic definitions, and then we'll talk about some of the causes, and in particular, focus on atrial fibrillation and then an entity that we're calling atrial cardiopathy. And then talk a little bit about practical therapeutic applications and the Arcadia trial, as I mentioned. Next slide. So this is the clinical entity that we are considering. So here's an MRI scan from a 57-year-old man who just presented with a rather brief episode of left arm and hand weakness and numbness, quickly recovered, but his MRI scan here shows a small infarct in the right frontal lobe. That little bright area that you can see there is an area of abnormality on a diffusion-weighted MRI scan, exquisitely sensitive to the earliest changes of ischemia. So a very small infarct on the surface of the brain. And this entity has been called cryptogenic stroke since it was first described as such by Dr. J.P. Moore, who is one of my mentors at Columbia University in New York, and first described these kinds of cases. Next slide, please. And this patient had an extensive evaluation and no specific cause of his stroke was found. And so that's why we call it cryptogenic, meaning a stroke of undetermined cause, essentially an unexplained stroke. And these are in fact quite common. So here I'm showing data from the Northern Manhattan study, which is the study that was initiated by Ralph Sacco at Columbia. He was another mentor of mine, and we continue to collaborate even though he's now at the University of Miami, where he's the chair of neurology. But the Northern Manhattan study has continued for almost 30 years now. And here you can see the different stroke subtypes within our cohort. So about 20% of strokes in Northern Manhattan are due to cardiac emboli from well-defined sources like atrial fibrillation. About 20% are due to atherosclerosis. And you can see here that's roughly evenly divided between intracranial and extracranial disease. And this is very different, right, from coronary artery disease, right, which is atherosclerotic in 95% of cases or so. It's a common but much less common cause of stroke. About 25 to 30% of strokes are due to lacunar disease of the very small blood vessels deep within the brain. And then even after thorough evaluation, about 30 to 40% of strokes are considered to be cryptogenic or unexplained. Next slide, please. Actually, you can advance it once more. Yeah, thanks. So here is the classic definition of a stroke of undetermined origin. And this definition comes from a clinical trial called TOAST, which was done back in the 90s. And basically, they described this as a brain infarct not attributed to a definite source of large vessel atherosclerosis, cardiac embolism, or small vessel disease in the presence of an extensive evaluation, an incomplete evaluation, or even in the evidence of more than one competing cause. In other words, if somebody had both a carotid stenosis and atrial fibrillation, you would have to say, I don't know why the stroke occurred, and so it would also count as unexplained. And we'll come back to this definition in a moment, but this is the definition that we've been using for many years. Next slide, please. So when a neurologist like myself is faced with just about any stroke patient, we go through a series of steps. These would actually be done more or less in parallel. Of course, in every patient, a history, examination, we'll be doing routine blood tests, and then an electrocardiogram to look for evidence of a cardiac rhythm disturbance, and then essentially imaging, and broadly we can think of imaging as imaging the brain, the blood vessels, and the heart. Next slide, please. Sometimes you get the answer just from the history and the examination. Often imaging will show us what we're looking for. Here's one type of stroke. This is a 48-year-old Black woman with a history of untreated hypertension who had rapidly progressive right-sided weakness. So her MRI scan here shows this tiny little infarct in the left side of the brain, down deep in the internal capsule. And this would be classic lacunar infarction. So this is an infarct due to blockage in one of the very small blood vessels deep within the brain. And the pathological slice down there at the bottom illustrates what these small blood vessels look like when cut. This is obviously a coronal slice. And here you can see the very small blood vessels coming off the larger ones at the base of the brain. And the small blood vessels are really little thread-like vessels going deep into the brain substance, giving you a stroke like this, usually from hypertension or diabetes or potentially other risk factors. Next slide, please. So that's a very small stroke there, but often people will think, oh, a cryptogenic stroke or an unexplained stroke is a small stroke as well. But cryptogenic stroke is actually not defined by its size. So if you just advance that once more, you'll see that slide I showed at the beginning of the gentleman, 57-year-old man with the right-sided stroke. And you can see that his stroke is actually just about the same size as that so-called small vessel stroke deep within the brain. And yet we think of these very differently. One is an end vessel. The cryptogenic stroke is an end vessel on the surface of the brain, more typical for an embolism. The other is a deep blood vessel affected by a high blood pressure or diabetes. So size alone cannot distinguish these. Next slide, please. And here you can see an example of why that is. Here's a case of a 78-year-old man with a history of hypertension and rheumatoid arthritis, and he presented with acute confusion. Interestingly, he went to see his doctor as an outpatient. He did not go to the emergency room, and he was sent for an MRI scan, and then that showed these abnormalities here, and when he was examined subsequently by a neurologist, he was found to have a very mild left hemiparesis. And so you can see this gentleman has multiple infarcts in the right side of the brain, rather large, although obviously clinically he did quite well. And so size here can be quite large as well with these. Next slide. So although we don't define cryptogenic stroke by size, we can define it by its location. So if you look here, the slide on the right shows Our Lady with the hypertensive lacunar stroke. And I think if you just click once, I have arrows and things in here, so that will illustrate this. So here you can see one of these small infarcts due to blockage in the small blood vessels. And then if we consider our 78-year-old man, if you don't mind clicking twice now, yeah, so he has the small infarct on the surface of the brain. But in addition, click once more if you don't mind, he has this deep infarct too, which is usually due to blockage in multiple of the small blood vessels at the same time. So this would be consistent with an embolism to the middle cerebral artery stem that causes distal infarction as well as deep infarction at the same time. Next slide, please. Okay, so imaging the blood, so that's imaging the brain, which often gives us an answer. Then we have imaging the blood vessels. We do this now in any of several different ways: ultrasound, MRA, CTA, or rarely conventional angiography as well. And if you click once more, here you can see an example of carotid stenosis on an angiogram, admittedly a rather old slide that I'm still showing here. And if you click once more, we can see a stenosis on the right side in that right distal carotid artery. And I show this again just to remind people that although the blood vessels in the neck are the ones that are accessible to the surgeons, we do like to look at the intracranial vessels for evidence of stenosis as well. Next slide, please. Okay, and then we image the heart. And I put this in quotation marks because some of this is conventional imaging, if you will, with ultrasound, like echocardiography. But let's think of electrocardiography as a form of imaging the heart as well. It's function or functional imaging. Next slide. So EKG and transthoracic echocardiography would be the main ways. And then in many patients will go on to do transesophageal echo, bubble tests looking for shunts and PFO, and then in some cases cardiac MRI, and then the really more intensive cardiac rhythm monitoring with telemetry or Holter or extended monitoring. We'll talk about these more in a moment. Next slide, please. And what we're looking for there, of course, primarily atrial fibrillation, but many other well-established sources of cardiac embolism. So the list here shows things that are well accepted to lead to thrombi in the heart that can then embolize to the brain. So AFib at the head of the list, but many other possibilities, including things like valvular vegetations and even rarely myxomas. Next slide, please. I think I show a slide there. Yeah, just illustrating the atrial myxoma in the left atrium, which can be a source of stroke as well. Next slide, please. So let's go back to that definition I showed you before, and you'll notice now I've highlighted in red the fact that that definition permits an incomplete evaluation. So essentially it says that a stroke of undetermined origin is a stroke in which there hasn't been an evaluation. And that's true, but that definition really leaves something to be desired then. And that's why, if you'll advance to the next slide, you can see that, if you could just, yeah, thanks. Now we are talking in the field, not so much about this entity of cryptogenic stroke, but the field has moved on to this notion of embolic stroke of undetermined source, or ESUS. And in this case, what we require is that a patient actually have a full evaluation to establish that it's not one of those small vessel lacunar strokes, that there's no narrowing of any of the vessels that would supply the area of 50% or more, and that there's no major cardiac source of embolism by doing at least a transthoracic echo and 24 hours of rhythm monitoring, and that no other specific cause has been identified, like vasculitis or hypercoagulable state and so forth. Next slide. And so that has led to this concept of ESUS instead. Now, the other thing to be aware of is that cryptogenic stroke, or ESUS, is also not characterized by the presence or absence of risk factors. Whenever we see a stroke patient, we like to think about their care, if you will, on two different tracks. One is understanding the cause or the mechanism behind the specific stroke that they're presenting with. The other is their risk factors. So if somebody has a superficial infarct and they happen to have high blood pressure or diabetes, we don't just stop there and say, oh, you have diabetes, that's why you had the stroke, you know, we don't need to do any further testing. We do the other testing to look to see if they have a carotid occlusion, to see if they have atrial fibrillation or some other heart abnormality and so forth. So it's always a question of looking both for the proximate cause of the stroke as well as their risk factors. Next, I think if you click through, I just illustrate those. Yeah, next slide, please. And there's always been a sense that these superficial small infarcts are embolic, that even though we haven't identified the source of embolism, that they are embolic in nature. And there's actually been some neat data recently furthering that concept. So what investigators did here in this slide, what I'm showing is that now that we're doing so many thrombectomies, pulling the clots out of patients in acute stroke, we can actually look at the clots under the microscope. And when this group of investigators did this, this was data from Germany, they looked at the composition of the clots based on the cellular types, platelets, white cells, and red cells within the clot. And I apologize that the lettering is so small here, but essentially what they found is that that second group from the left, which is the kind of definite cardioembolic group, you know, known AFib, those clots look very similar in characteristics to the group all the way over on the right, the cryptogenic strokes. They share the same clot characteristics, which again, it's not proof, but it's supportive of this idea that cryptogenic strokes are also embolic, even though we haven't identified the source yet. Next slide, please. So this has led to some large trials, actually, clinical trials, that took the point of view that if these patients are in fact embolic, then using anticoagulants should benefit them just like it does patients with atrial fibrillation. And so there were two large industry-sponsored trials, the Navigate ESUS and Respect ESUS trials, enrolling, as you can see, almost 7,000 patients each. Disappointingly to those of us in the field, they did not show any benefit to anticoagulating unselected patients with embolic stroke of undetermined source. No real statistically significant difference in treatment with an anticoagulant in these groups. Next slide. And in many ways, we would say this is not too surprising. It was a good idea, but perhaps it's not surprising because this category of embolic stroke of undetermined source is really quite heterogeneous. And in the past, we tried to lump all those together, but now we recognize that there are probably many different subcategories within this group. And as my colleague Human Kamel and Babak Navi from Weill Cornell Medicine, this lovely figure comes from some of their work. One can divide up the categories of ESUS into types that may reflect cardiac disease, and you can see off to the left there, this atrial cardiopathy without atrial fibrillation. We'll talk about that more. Subclinical atrial fibrillation, silent myocardial infarction, PFO, perhaps occult cancers as well that can lead to a hypercoagulable state. Those might be the ones that would respond to anticoagulants, whereas the ones on the right side, so atherosclerosis without a significant stenosis, right, where the plaque is primarily in the vessel wall rather than in the lumen, and other types of vasculopathy might be expected to respond better to antiplatelet therapy. This is the hypothesis. So what we've set about to do is to try to deconstruct this entity of ESUS. Next slide, please. Okay, so this is obviously a fraught political time in this country. I'm not going to go there with anybody here, fortunately, but I would just like to harken back to one of our past times of some political upheaval as well. Some of you may recognize Donald Rumsfeld here, who was who's the Secretary of Defense when we went into the war in Iraq. So he had a statement back at that time for which he got a lot of flack, but I would say there's actually quite a bit of wisdom in this statement. So this is what Don Rumsfeld said back in the early 2000s. He said, there are known knowns. These are things we know that we know. There are known unknowns. That is to say, there are things that we know we don't know, but there are also unknown unknowns. These are things we don't know we don't know. And I would suggest that this statement, as kind of windy and crazy as it is perhaps, says a lot that makes sense for a cryptogenic stroke. Next slide, please. So there are many known knowns. Those would be things like atrial fibrillation, subclinical atrial fibrillation. There are then many known unknowns. And these would be some of the things that I'm showing here. These are all the potential causes of embolic stroke of undetermined source. And there are many of them that you can see there, from hypercoagulable states, infections, vasculopathies, sleep apnea, and so forth. We're not going to go into all of these, of course, in detail. But then even beyond this, if you just click once more, are going to be the unknown unknowns. And these, I would posit, these are things that are still being researched or discovered. One of these may be COVID-19, right? We've seen these large vessel strokes in patients, especially young people, often without other risk factors, due to COVID-19. Thankfully, it's rare, but it does occur. And so there's still a lot more to learn about COVID, of course, and unexplained causes of stroke. Next slide, please. So we like to use this little algorithm to take us through the evaluation of a patient with stroke or TIA. They first come in, we do that routine baseline assessment that I mentioned, where we're doing some blood tests, we're imaging the heart, blood vessels in the brain, and that's how we identify the known knowns. We find the thing that, carotid stenosis or atrial fibrillation, and then we identify the stroke mechanism off to the left in green, where, we're good to go. We know how to treat it. When a stroke mechanism is not identified, then we often will think about, is it a small vessel stroke? Is it a lacunar infarct? Then we go back off to the left there, and if they have risk factors like high blood pressure or diabetes, then we'll say, okay, that explains the stroke mechanism. But if they have small vessel stroke and no risk factors, or they have a cryptogenic stroke, so that the initial set of tests doesn't identify the cause, then we will begin to look for these known unknowns. We'll do transesophageal echo. We'll do monitoring of the heart for paroxysmal atrial fibrillation. We'll look for intracranial vessel abnormalities, particularly wall abnormalities, and perhaps do more advanced blood tests looking for infections and vasculitis and things of that sort. So this would be an algorithm for approaching these patients. Next slide, please. But what are the common potential causes? Well, paroxysmal atrial fibrillation, other less well-documented sources of cardiac embolism, like patent foramen ovale and this entity atrial cardiopathy, which we'll come back to, and then hypercoagulable states and vasculopathies as well. So we're going to focus on the cardiac causes today. Next slide, please. So the cardiologists, and I understand there are many cardiologists on the webinar tonight, divide atrial fibrillation up into these various categories: paroxysmal, persistent, permanent, and so forth. Next slide, please. And I would argue that to neurologists, the entity that's really most important is this entity that we call occult atrial fibrillation. So this would be paroxysmal atrial fibrillation, but AF that's very hard to detect. And in fact, it's not even clear how brief an episode of atrial fibrillation is relevant. Next slide, please. Why is it so important to find atrial fibrillation? If you just click once more, it's because we know that anticoagulation is so effective at preventing recurrent stroke. About 70% reduction in risk with anticoagulants versus placebo, 30 to 40% compared with aspirin. Next slide. Yeah, that's great. And in fact, it's the only common stroke mechanism for which we know anticoagulation is a benefit. Right? So when I was in training, 20, 30 years ago, many of you were in training. If you were exposed to stroke, you probably heard people say, oh, these patients should all be anticoagulated. But many studies through the years have shown us that that's not the case. It's not the best thing for everybody, except for patients with atrial fibrillation. Next slide, please. But atrial fibrillation can be very difficult to discover, right? So it can be paroxysmal, and in fact, it can occur very infrequently. Right? It can be present on less than 10% of the days, or for less than an hour, a couple of hours a day. So it can be hard to find. In fact, many patients initially present with their atrial fibrillation through having a stroke. Right? So that's the first manifestation of their AFib. Next slide, please. And symptoms are virtually worthless for detecting atrial fibrillation. People can have symptoms and have no AFib. They can have AFib and have no symptoms and so forth. So that can be very difficult to use. Next slide, please. But we do have many other ways of detecting it currently, all the way from the history of symptoms through EKG and all the way up to implanted loop recorders. Next slide, please. Some of these monitors that we have available now can stay in for a long time and provide us information. And we're going to come back to this. Next slide, please. Currently, our guidelines recommend that people get a 12-lead EKG on admission and at least 24 hours of continuous cardiac monitoring. And the question exists, how long should people be monitored, especially now that we have longer-term monitors available? Next slide, please. The studies have suggested that the longer a person is monitored, not surprisingly, the more likely one is to detect atrial fibrillation. And in patients with unexplained stroke, the evidence has suggested 25 to 30% of patients monitored long enough will have atrial fibrillation detected. Next slide. But much of that data is really based on case series or small studies. They use different definitions of cryptogenic stroke. They use different definitions of atrial fibrillation and so forth. So there were a lot of limits to those kind of observational studies. Next slide. And so that led to a couple of clinical trials that are worth knowing about. One was called the Embrace trial, conducted in Canada, in which they looked at 570 patients who had unexplained stroke or a transient ischemic attack within the last 6 months. They had a mean age of 73, and their evaluation had to be negative, and only 8% of the patients actually underwent a transesophageal echo. And they compared a standard 24 hours of monitoring to a full 30-day event monitor. And their outcome was 30 seconds of AF by 90 days. Next slide, please. And they found that the 30-day event monitor was much more effective at detecting atrial fibrillation than the 24 hours of telemetry alone. You can see the differences there. And if they looked at a different definition of atrial fibrillation, it was still much better. And in fact, patients were much more likely to be changed from an antiplatelet to an anticoagulant if they had the 30-day monitor. Although this study was not designed to capture the benefits on reducing clinical outcomes like recurrent stroke, it showed that there was a change in management. Next slide. The second study to be aware of was called the Crystal AF study. And this also industry-sponsored study looked at 440 patients with unexplained stroke. Again, no history of atrial fibrillation. They had to be over the age of 40. They were a younger patient population, and everybody had a transesophageal echo to rule out other sources of potential embolism. And in this study, they compared the 24 hours of monitoring, just like in the Embrace trial, but here they compared it to an implanted cardiac monitor, right? One of these stick of gum-like monitors that goes under the skin and can remain there for up to 3 years, continuously recording the heart rhythm. Their endpoint was also 30 seconds of AF by 6 months. Next slide. And what they found was that there was a much higher rate of detection of atrial fibrillation with the implanted monitor. By 6 months, it was 6-fold. And if you advance to the next slide, you can see the, one more, if you don't mind. Here you can see the rates of the detection at 12 months and 36 months as well. And so you can see by 3 years, 30% of patients with an implanted monitor were discovered to have AFib, compared to only 3% who had the standard monitoring done. Big benefit in favor of the implanted monitor, but versus standard 24-hour monitoring. Next slide, please. So what we, and they also were able to show here that the recurrent stroke rate was lower in those who had the monitor placed. Although the study was not powered for this endpoint, you can see that there was evidence of a difference. Again, it was not a clinical outcome study. Next slide. And in fact, because it's not a clinical outcome study, this hasn't changed at least the AHA guidelines. So what we've discovered from these two trials is that 30 days of monitoring is better than 24 hours of monitoring, and that having an implanted cardiac monitor for up to 3 years is better than 24 hours of monitoring. But if you click once more, we haven't been able to compare the difference between 30 days and the 3 years. We do see that it changes management, although no impact on clinical outcomes. And click once more there. So I think, and again, sorry, I guess I was setting this up as I would be clicking through. It's a little more complicated this way. So we don't have the question about which is better, 30 days or longer, and does the monitoring reduce the risk of stroke? Once more, please. And I think that'll go to the next slide. Great. So that tells us that monitoring can detect atrial fibrillation. But what I'm showing here is that if you think about it, even among those who are monitored for 36 months, only 30% are found to have atrial fibrillation, which means that there's another 70% out there who could have other mechanisms, perhaps. And so the question is, what else is out there? Next slide, please. And so in recent years, we have really begun to question the traditional idea of how atrial fibrillation causes stroke. And that's for a number of different reasons. So it turns out that if you look at patients who are enrolled in studies where they are wearing implanted cardiac devices like pacemakers and so forth, that they will go on to have episodes of atrial fibrillation and stroke, but those aren't necessarily temporally related to each other. People can have stroke even though they may be many, many days, a month or more apart from when they were in atrial fibrillation. So the idea that you're in atrial fibrillation and that shoots the clot up to the brain may not be entirely correct. Next slide. In addition, we know that people can have ectopy, and that can be associated with stroke even before they have atrial fibrillation. They can have genetic mutations that predispose to atrial fibrillation and have stroke before the AFib occurs itself. And you can even have electromechanical dissociation between the atrial contraction pattern and paroxysmal atrial fibrillation, so that it can look like sinus rhythm on the EKG, even though the heart is actually fibrillating, the atrium is actually fibrillating. So our traditional notion of atrial fibrillation and its relation to stroke may be problematic. Next slide, please. And so this led us, again with my colleague Human Kamel and others, led us to set forth a different way of thinking about the relationship of atrial fibrillation and stroke. And that traditional idea that I think most of us learned in medical school with regard to this fibrillating bag of worms, right? That the atrium are fibrillating and that leads to stasis, and that's where the clot forms, may not be entirely correct. There are many other mechanisms within an abnormal atrium that may lead to stroke, like inflammation, endothelial dysfunction, fibrosis, and so forth that can lead to clot without the fibrillation per se. Next slide. And so we would propose that if the old way of thinking about atrial fibrillation is as chronic atrial fibrillation and paroxysmal atrial fibrillation, next, if you click once more, that would be the tip of the iceberg. And this occult atrial fibrillation, where you capture it with monitoring, may be a big chunk under the surface. And if you click once more, there may in fact be a lot of other, and click again, apologies. So we are considering this entity called atrial cardiopathy as a cause of stroke. And if you click once more, you can see that there are a number of different other manifestations of an abnormal atrium that may then be associated with risk of stroke. And these essentially are biomarkers that can detect an abnormal atrium that may be at risk of stroke. And there's a lot of evidence to support this idea. Next slide, please. My colleague Human Kamel has done work showing that, for example, paroxysmal supraventricular tachycardia, so a non-atrial fibrillation cardiac rhythm disturbance, may be associated with the doubling in the risk of stroke, even in the absence of atrial fibrillation. Next slide. You can actually measure the, and I apologize, I don't know whether all these horizontal black lines on the slide, they came from somewhere else, I suppose. But at any rate, the lead that sits, lead V1 sits over the left atrium, and the terminal portion of that EKG tracing reflects the contraction of the left atrium. And you can measure the depth and duration of the P wave in lead V1, and that gives you a measure of contraction of the left atrium. And so one can look at abnormalities of the P wave, and next slide, those have actually been associated with the risk of stroke. So, and I think you can click through this. This is just some data from the Northern Manhattan study showing that elevations in that P wave, it's called P wave terminal force in lead V1, is associated with an increased risk of cryptogenic or cardioembolic stroke. Next slide, please. And similarly, you can click once more if you don't mind. Similarly, cardiac biomarkers, blood biomarkers like NT-proBNP or cardiac troponin can also reflect this kind of abnormality. And next slide, be associated with an increased risk of stroke. So this is data from the cardiovascular health study showing that even after adjusting for AFib, CHF, left ventricular hypertrophy, levels of NT-proBNP are associated with an increased risk of stroke. Next slide. And you know, the other thing is that there are other echocardiographic risk predictors of stroke, and some of these are obvious, like the size of the atrium and so forth. Next slide. But there's also evidence that the left atrial appendage, which is where most blood clots reside in patients with atrial fibrillation, can have different morphologies. If you click once more, and again, there are actually many different morphologies of the left atrial appendage, and they have these kind of fanciful names. But you can imagine that somebody who has a cauliflower-shaped appendage is going to have lots of nooks and crannies where blood clots may be sitting, and those could then embolize. And in fact, next slide, there is evidence that those who have the other morphologies other than chicken wing tend to have a higher risk of stroke than those with this chicken wing morphology. Next slide, please. So it's possible that people with these abnormal or variant morphologies may be at increased risk of stroke, even in patients without atrial fibrillation. And of course, cardiac MRI can be used to explore cardiac function and structure that may lead to stroke as well. Next slide. So this has led us to hypothesize that it could be that vascular risk factors, of course, can lead to stroke through non-atrial stroke mechanisms. They may lead to an abnormal atrial substrate that leads to AFib and then stroke. But we would propose, next slide, that in addition, it may be that the abnormal atrial substrate itself can cause a stroke. Next slide. And next slide, please. You may wonder why it matters. Well, it matters because it could have clinical implications. And I know we're getting near the end of time. I'll just take a couple of more minutes if it's okay, Dr. Murthy. So this is the data from the WARS study, Warfarin-Aspirin recurrent stroke study, and this is Dr. Moore here, and he did this study many years ago to prove whether warfarin was in fact better than aspirin for patients with non-cardioembolic stroke. So these were not patients with atrial fibrillation. They were excluded from the trial. And in fact, he was unable to prove that anticoagulation was better than aspirin for the unselected patients with stroke. But what he found, or what we found, next slide, is that because blood samples were stored from those patients, we were able many years later to go back and look at the stored blood specimens, and we found that those patients enrolled in the WARS trial, right, they were randomly assigned to warfarin or aspirin, those who had elevated levels of NT-proBNP did better on warfarin. Warfarin was significantly better for them than aspirin, whereas those without elevations in NT-proBNP did not see a benefit with warfarin. So this suggests that anticoagulation may be of benefit for those who have biomarkers of atrial cardiopathy. Next slide. And so that insight, if you will, led us to create this trial, design this trial called Arcadia. And you can see what it stands for there on the slide. And this is work done together with Dr. Kamel, as well as Will Longstreth and David Tershwell at University of Washington in Seattle. Next slide. This is an NIH-funded trial. It's a multi-center trial. We're doing it in the US and Canada. It's being done through what the NINDS calls the StrokeNet mechanism. We do have some industry support, as I mentioned at the beginning, in terms of drug and laboratory support. And our primary hypothesis is that apixaban, right, one of the newer oral anticoagulants, will be better than aspirin for preventing recurrent stroke in patients who have unexplained stroke, but who also have this entity of atrial cardiopathy. Next slide. And so patients have to be at least 45 years of age. They have an unexplained stroke. They've had a full evaluation. So it's an ESUS, an embolic stroke undetermined source, despite a full evaluation. They actually, now we are allowing enrollment up to 180 days, in part because of the COVID crisis and its interference with the study. And they have to meet one of these three biomarkers on evaluation. Elevation in their P-wave terminal force on that lead V1, elevation in serum NT-proBNP, or severe left atrial enlargement on echo. Next slide. And our primary, and they can't have any atrial fibrillation or severe heart failure or significant stenosis in a vessel. Next slide, please. Primary outcome is recurrent stroke. We'll be looking at safety outcomes. We're screening 4,400 patients with unexplained stroke, of whom we expect a quarter will be actually will have atrial cardiopathy and then be randomized. Next slide. And this is where we are so far in the study. We have about 140 sites. We're adding some more. We have over 1,700 patients screened and 461 now, I think, randomized. And we have a couple of ancillary study that's been funded to look at cognition as well, and another one looking at genetics that we hope will get funded. Next slide, please. So sometimes I call this talk a little bit sarcastically, perhaps, why neurologists won't care about AF in the future. The idea is that these biomarkers, like the P-wave abnormality or NT-proBNP, may replace atrial fibrillation in the future. And they have the advantage of being measured at one point. You don't have to wait for all the monitoring to be completed to get your answer if the patient has PAF. You'd know on day one, essentially, if they should be anticoagulated or not. So next slide, we could do away theoretically with and click once more, with the implanted monitors. Again, probably not making the cardiologist too happy here. There are many other types of, or causes, as we talked about, of ESUS as well. Colleagues of mine were designing a trial to look at patients with unexplained stroke and cancer, for example, and these other categories may need to be treated separately as well. So we need to move away. This is really it's a form of precision medicine, identifying the specific subgroup within the unexplained stroke category. Next slide, please. And I think we can go through this. to the next slide, I'll just acknowledge my collaborators, Dr. Sacco and other colleagues in the Northern Manhattan study, support from the NIH, of course, and some other funders. Next slide, please. And also my colleagues from the Arcadia trial and the CHS study as well. And so I apologize for going over my time a little bit, but I think we still have about 10 minutes or so, and I would be happy to entertain questions. And again, thank you so much for this wonderful opportunity on behalf of myself. Thrilled to be able to talk to you about this, and on behalf of the American Heart Association for inviting us to be here this evening.
Thank you, Dr. Kim, for your comprehensive presentation. I remember the 1990 Global Burden of Disease study ranked the cerebrovascular disease as the second leading cause of death after ischemic heart disease. And unfortunately, even after 30 years, it is still one of the leading causes of morbidity and mortality globally. Thanks for representing the American Stroke Association today especially. It is very close to us.
Appreciate that.
Now, Dr. Guntupalli will lead the question and answer session. I also request the co-chairs, who are also our panelists, to contribute. Dr. Guntupalli. I think we need to unmute her. Thank you.
Thank you so much, Dr. Elkin. That was an outstanding overview with a scientific rationale explained. I have several questions from the audience. What is the treatment of choice for cryptogenic stroke? This is from Divya Jan Mahapatra.
Yeah, well, that's a great question. And at the present time, the treatment of choice is aspirin, as well as controlling risk factors. So almost every stroke patient now will get treated with aspirin, with a statin, right? So there's evidence that regardless of cause, a statin reduces the risk of recurrent stroke. And most patients will also be on a blood pressure medicine. There's even evidence that even in the setting of normal blood pressure, stroke patients do better on blood pressure medication. So aspirin is kind of the default antithrombotic strategy, and the question is whether anticoagulation should be used. That's what we haven't established yet.
The next question comes from Dr. Mahadevappa. He's asking you, what is your opinion regarding coexisting obstructive sleep apnea with AFib, and what is the prognosis in these patients?
Well, yeah, I'm glad you asked that. Obstructive sleep apnea is a growing, increasingly recognized cause of stroke, probably through a few mechanisms. One would be through causing atrial fibrillation, maybe paroxysmal atrial fibrillation, and also because of its effect on hypertension. So that would be a, the relationship between them. The prognosis is, if they have poorly controlled sleep apnea, it's often not good. There's actually a large trial going on now called Sleep Smart, which is addressing this question of whether patients with unexplained stroke and sleep apnea should get CPAP, and whether that will, number one, reduce their risk of recurrence, and number two, reduce their or improve their functional outcome after stroke. There's evidence that sleep apnea impairs recovery, and so there may be double benefit there with it.
I have a question from Dr. Nigam, who is asking about a patient going for emergency exploratory laparotomy with new onset of atrial fibrillation that was found in the emergency room. Cardiology inclined to do echo post-op than pre-op. Would there be any value to know about any left atrial clot during emergency surgery? If yes, what can be done in that situation?
Well, that sounds like a tough situation where you have, just two bad things going on. You're caught between a rock and a hard place. The patient needs the surgery. It's an emergency. And they're not going to be able to get anticoagulated immediately, even if a clot were found. So in the absence of a stroke or a cardiac problem occurring at that time, I think you take the patient to surgery, you do the surgical procedure, and afterwards perhaps evaluate them for the atrial fibrillation. And if you identify a clot or evidence of stroke, perhaps in the past, then they might be a candidate for anticoagulation. Then you get into the question of which patients with atrial fibrillation who don't have a stroke should be anticoagulated. So it would depend on the patient, I think.
A question from Dr. Sushma Manda. She's saying that asking you, can 2D echo with bubble study be used instead of TEE to minimize length of stay in hospitalized stroke patients?
Yes, and we often will do that, in fact. Yeah, that's safety may allow us to do that, sure.
What is Dr. Edward Lin is asking you, what is best management strategy for stroke apparently related to a known malignancy recently treated?
Yeah, so that is a question that is not yet answered, and we hope to address that in a trial that will randomize patients with recently diagnosed cancer and stroke to an anticoagulant, also apixaban versus aspirin. Many people are anticoagulating those patients. I think there's a bias towards that among oncologists rather. But the fact is we don't really know for sure what's better. Many of these patients can actually go on and have bleeding complications in the future. So we don't want to assume that they should necessarily be anticoagulated. We need
the next question is from Dr. Lola Bhatt. He's asked, every stroke TIA needs to go through TE with loop recorder.
Whether every patient needs to go through it, was that the question?
Correct. Every cryptogenic stroke.
Yeah. So it's a really good question, and we don't have great evidence on which to make definitive recommendations on that. Our practice is not to do it in every patient, but in people who who are older, who have other evidence of heart disease, we may do more cardiac monitoring and look for atrial fibrillation. In younger people, sometimes teenagers, PFO can be a not uncommon cause of stroke. It may account for 25% of strokes in very young people. So in those cases, we'll definitely do transesophageal echo. In a young person, I will usually get a TEE, not just for PFO, but also to look for rare things, myxomas and morantic endocarditis and things of that sort.
The next question is from Dr. Raj Alagappan. He's asking you, with growing evidence of arterial calcification and warfarin, would you still consider this on a long-term basis?
Warfarin for long-term treatment, is that the question?
Yeah, correct.
Yeah, so, well, I would say we're using warfarin much less frequently now. We're using the newer oral anticoagulants because their safety profile, quite frankly, is better. Their risk of intracerebral hemorrhage in particular is better. And they're just as effective, in some cases, perhaps even more effective. And so for many reasons, we're using warfarin a lot less frequently now. I think, there may be some patients in whom you want to be able to monitor the level and keep a closer eye on them for some reason where it still may be appropriate. But in general, we use very little warfarin now.
The next question comes from Dr. Nitin Doshi. Is there any role of novel anticoagulation or antiplatelets as treatment for lacunar infarcts from small vessel disease?
So for small vessel disease, there really is no evidence for the use of oral anticoagulants. We do use antiplatelets. The standard would be aspirin. There was a large trial called the SPS3 trial, a government-funded study, which did not show any benefit to using two antiplatelets together, aspirin and clopidogrel. That study did not show any benefit for combined therapy. At the same time, there are some studies that have shown that in patients with mild stroke, there may be a benefit to being on two antiplatelets, aspirin and clopidogrel, for a period of perhaps a week or maybe even as long as 30 days. That's not specific to lacunar stroke, but there may be some benefit for a short period of time. You may decrease the early recurrence without increasing the risk long-term of hemorrhage.
A follow-up question from Dr. Amanda. She's asking you if prolonged Holter or implantable loop recorder, which one would you prefer?
Yeah, so that's, we just don't have an answer to that question yet. As I showed, the head-to-head data between, say, 30 days versus 3 years has not been answered. We just don't have that data yet. That said, our clinical practice has usually been to do a 30-day monitoring, and if there are suggestive abnormalities, some atrial ectopy short of atrial fibrillation, equivocal episodes and so forth, then to do a longer-term monitor. I will tell you, many patients do prefer having an implanted monitor. It's more comfortable for them. And so in many cases, with patient preference, we'll put in an implanted monitor earlier, especially in older patients in whom our suspicion that will detect AFib is higher.
I think there may be a couple of more questions coming, but I think we are 8:01 already. So thank you so much. It's an excellent presentation.
Dr. Guntupalli, we started late, so you can have the questions for another 4 minutes. No problem.
Okay. Dr. Nayak is asking, should patient with patent foramen oval should be closed?
Yeah, that's another super question, and a very exciting area of clinical activity now, and I think it's a wonderful example of where the worlds of cardiology and neurology come together again around closure of PFO. So I would say in short, yes, there is good evidence now that some patients, selected patients with unexplained stroke who have a PFO may benefit from closure. And so we do recommend it. Usually it's patients, again, who are younger, who don't have other risk factors that might have explained the stroke. There should be agreement between the neurologist and the cardiologist that it's an appropriate procedure for a given patient. And so in selected patients, we will close those PFOs. But we don't want to open the floodgates and do it in everybody. 70-year-old person with a stroke who may have some other cardiac source, not going to rush to close that PFO. So it takes a lot of judgment.
I think that kind of covers all the questions. And thank you very much. And I appreciate your willingness to give this wonderful talk late in the evening. Thank you so much.
Thank you, Dr. Guntupalli. And thanks again, Dr. Elkin. We are now close to concluding the program. I request Dr. John Lagada to give a vote of thanks. Dr. John Lagada?
Yeah, thank you. Thank you, Dr. Mutkar. Vijay, can you put the slide on, please? Thank you very much, Dr. Elkin, for eloquent talk. It is a treat for our members as an inaugural speech from you. And on behalf of American Association of Physicians of Indian Origin, recognizes Michelle S.V. Elkin, MD, for his outstanding contribution in neurology and welcome him as a member of API Distinguished Speakers Club. Sudhakar John Lagada, MD, President API, and Vemuri S. Murthy, MD, Chairman API Webinar CME Committee, July 29, 2020. Thank you very much. Thank you.
Thank you very much. Greatly appreciated.
Yeah, thanks everybody. This concludes our program. Good night.
Good night.
Thank you.